20% broad brush on average. Now, all of the literature, even the literature like the famous Melby study that reassures women that there's no problem with abortion and breast cancer, if you read not just the abstract, but you go into that study and you look for the details about the further along a woman is, the closer the link to breast cancer. And you say, why is that? How can a full-term pregnancy cause you to have lower risk and cutting it off is potentially not reassuring to women? And that's the best scientific way I can put it. I'm not saying it's cause and effect proof. It's not reassuring data. And the plausible biological mechanism is that estradiol levels go up. They go up every cycle. They go up double at the time of LH surge. And in pregnancy, go up 100-fold. What's the first sign a woman has when she's pregnant? Before the HCG is positive, days before, a week before, her breasts are sensitive. It's a picogram amounts of estradiol. We're talking about 8 zeros after a decimal point and a number. The breasts are responsive to picogram amounts of estrogen. And so for 6 months, until you get into the last trimester of pregnancy, the breasts go through what you've learned about in the first year, proliferation, where the cells go through mitotic phases, and that's a higher risk time for any cells. It's mitotic division. Part of why vitamin D is inhibitory on cancer growth is because it inhibits mitoses. So it's a high risk time. And then the last, you go through differentiation, where basically the breasts, the acinar units, become hardened, and if you will, they have less risk, not no risk, of breast cancer after having a full-term pregnancy. And by the way, this will be disturbing news to all of you who postponed your own families and all, is that the earlier you do this, the better. You follow me? So when you're counseling people, the first thing, the principle is that you listen to what are her needs. And this is not rocket science. You do that with patients coming in. What do you want to get out of this visit? Anything else? Anything else? Tell me more. What do you think is going on? Feynman questions. The same kind of thing you do with people who are with an unplanned pregnancy and feel challenged about what to do. What's the next thing you do? You show compassion. Compassion means to suffer with. It means to be there present with the person, not necessarily fix anything. And then ask the same sets of questions like, what could be helpful to you? Now I get back to neutrality because are you neutral? I've shared my ethic. I believe in the inherent worth of all human life. I don't draw boundaries about it. I don't have ageism, sizeism. It's been critical in my fight against assisted suicide in Oregon, Washington, Montana. This next month will decide the election in Massachusetts, whether or not Massachusetts joins the liberal Northwest. And I say liberal because it's really not. It's empowering doctors and healthcare bureaucracies to make decisions about people's life and death. I think it's a very misguided, well-intentioned, misguided approach. So I have a value about life, whether it's old, I'm taking this personally, I'm getting older every year. And, in 2 years I'm going to be on Medicare, for better or worse, and I care about that. I care about you as a future generation. How valuable do you think my life is when I'm 85 instead of 65? Will you make different decisions about that? I take it very personally too, because my wife unfortunately has metastatic cancer. She has a leiomyosarcoma. And she was in the 80% that no matter how early you catch it, it goes to the lungs. It's one of those cancers that is rare enough that you don't have billions and billions of dollars in research. And we've gone through 5 chemotherapeutic agents, and the inexorable progress of the 100+ lesions she has in her lungs have not subsided. And just this week, we got that news. And we got the news that we've run out of options pretty well in allopathic medicine to do anything except for perhaps prolong the disease progression-free interval. But you can't cure. But if I'm on Aetna insurance because I'm a professor of family medicine at OHSU, if I were on the Oregon Health Plan and had fewer resources, what would they say about my wife right now? She has less than a 5% chance of being alive in 5 years. So we won't give you any treatment. We won't try. So some of you might be interested in oncology. What does that say for your field? We don't even try to push the envelope. What would it say to HIV patients in San Francisco in the early 90s if we said, well, this is 100% lethal, why bother? And now we've come around to having heart therapy. It took billions and billions of dollars in research to do that, to turn a a uniformly lethal disease into a chronic disease. In Oregon, people like my wife have gotten letters saying, we won't cover your treatment because it's considered futile. You're save those dollars, but we'll give you 100% coverage for pain relief and assisted suicide in the same letter. So regardless of how you feel about assisted suicide, isn't that a little bit of a sharing of value here? So it's difficult to be neutral. You can be neutral about some things. Give me an example of something you can be neutral about with no ethical implication. Hair color. Chocolate, vanilla. Fine. I don't care what I get. Give me ice cream. I like it either way. You can be neutral. Can you be neutral about other things like beating your wife, your child, having slaves, flying airplanes into buildings loaded with innocent people to make your political point, no matter how strong you feel about their point? I would label those things using the same simple word you used about smoking. They're bad. Now, I don't judge people who make wrong-headed decisions like continue to smoke. I have lots of smokers in my practice. I don't judge people who misuse drugs. I have lots of those in my practice. I don't kick them out of my practice. But I'm pretty clear, in a good-natured way. Sometimes I jibe, I thrust and parry to try to get them to be uncomfortable with their choice. You know, I'm going to have to give a talk on health promotion in a month at OHSU, as I've done every year for the last umpteen years. And one of the points I make is that you have to be willing to create some level of fear in people in order to change. And that's heresy because you've been taught fear-based strategies don't work. Has anybody ever heard that? No, maybe you've been taught correctly. I don't know. But if you think about this, if you're going to stop smoking, the most likely way to stop smoking is to maybe become pregnant. Why? Why does a mother stop smoking? She cares about the child. She's afraid of hurting the child. It's fear. You have a person with unstable angina. He's a smoker. You're talking about angiograms. You're talking about bypass surgery. You're talking about stents. Unlike the 3% spontaneous quit rate, or the 6% if you're really a good behavioral person like I strive to be, if I try to intervene and get her to stop smoking, there's almost a 50% response rate if you've got a need to stop. Like your heart's going to stop and you're going to die. You follow me? So if you don't share your values, you'll have a lot less impact on people if you think that things are better or worse with one way or another. And some of you may not know the literature about health risk. I've just told you one, that there is a linkage, a correlation between abortions, how far along, and breast cancer. There's lots of non-reassuring literature. There's some reassuring literature. And I encourage you to read it carefully. There's actually Joel Bryn who's done a study of studies, of 10 studies that showed there was no problem and showed the flaws in those 10 studies. And that got published in peer-reviewed literature. So educate yourself. So the other part is not only just hear her story, be compassionate, but know about resources and know about the implications of the advice that you give to somebody. Because I can tell you this from my colleagues who actually do abortions. One of them is one of my closest friends, and I've been a mentor for him, and he's very successful. He really comes down on people because he does abortions, and some people say, well, it's no different than removing a mole. Well, let me just share one little, give you some factoids here, because if you look, you actually can do studies of this, because you're often hearing how safe abortion is. I just told you with the anencephalic child, had she cut it off, she would have put herself at more risk, and she not only had closure, had no guilt about the life of that child and what happened to it. She did all she could for it, but she also did all she could for herself. So in Finland, they've done a study, and it's been replicated in California and also one of the southern states. It's harder to do here because it's not a captured population. But in Finland, they got a computer, and all women of childbearing age can possibly be tracked, or can be tracked. You follow me? So very simple. It's not a subjective study. It's looking at 4 categories of women. A woman can either become not pregnant, they can become pregnant, carry it to term, they can become pregnant and have a miscarriage, or they can become pregnant and have a so-called therapeutic abortion. If you take this as the risk of dying, and all-cause mortality is not blaming any specific issue, just are you alive or dead in 1 year? So you use your control group as the not pregnant people, and they call that 1. Relative risk of being dying is 1 because that's the control group. You follow me? Everybody with me? All right. So that's the risk of dying if you're not pregnant. If you're pregnant, you carry it to term. We know pregnancy has preeclampsia. You can get amniotic fluid emboli. You can get bleeding. You can lose your uterus if you have severe bleeding. So what's the likelihood of a woman carrying it to term being dead? Anyone want to take a guess? It's half. Why? Well, maybe because she doesn't go hang gliding. Maybe she uses her seatbelt more consistently. Maybe she doesn't smoke, she doesn't drink, she didn't reach for a cigarette and have a head-on crash. I don't know. It's all-cause mortality. You follow me? But whatever risks there are with pregnancy, in modern Finland, it's not so bad that this went above 1. You got me? All right, miscarriage, because it's early in pregnancy, I just give you the answer. It's about 0.9. And therapeutic abortion, I'm not blaming this on the procedure, but the relative risk of being dead in 1 year in Finland in this study was 2. So if you're about this because you want to keep it safe and legal and you want this gift to womanhood, I would encourage you to look at the literature. And look at it not with sound bites, not with drive-by debate, but look at what is the real issue here. And if you don't care about statistics and you want to talk about personal stories, I'd encourage you to read a book called Forbidden Grief by a psychologist who in her training discovered that much of the source of the morbid obesity in an obesity group she was running came from post-traumatic stress, and 9 out of 12 people can experience abortion. Now again, I'm not saying cause and effect. I'm just simply saying that it's so significant that 95% of the people who choose abortion regret their abortion. 5%, like the residency director at OB-GYN at Boyer Shoe, never looks back, and she's fine with it. They both exist. You follow me? I'm not here to say they don't both exist. People are diverse. But if you look at focus groups, Real Choices by Frederica Matthews Green, a feminist who was pro-choice, is pro-life now, she did focus groups of people. And she said, women don't choose abortion like you choose between vanilla and chocolate. Women choose abortion like an animal caught in a trap chews its leg off. She feels that she has no choice. And so, critically, what I think we ought to do is come around her, support her, and help her to make a real choice. Give her a choice. Now, some, despite our best efforts, will not. And so the final step in counseling women is to be totally accepting, just like I am with my smoking patients, my drinking patients, totally accepting of the fact she doesn't make a choice I might make myself, or my wife would make, or hopefully my kids would make. And in fact, she even needs more support because she's got 6 times, this is the death rate, but the suicidal ideation rate is almost 6-fold the background. You follow me? So much so that the British College of Obstetricians and Gynecologists recommended that you screen for depression with somebody who's abortion-minded. Now the ACOG, the American College, denies this reality. But